Pablo, estás en mute.
We cannot hear you, Pablo.
Olá muy buenos días a todos y todas y un feliz 2021. Gracias por conectarse a esta sesión informativa de la OPS sobre la pandemia por COVID-19 en las Américas. Soy Paulo Lira, del Departamento de Comunicación de la OPS. Esta sesión durará entre 45 minutos y una hora. Y también podrán hacer preguntas en vivo y a través del chat, mediante el botón Q y A. Recuerde sempre incluir seu nome e meio de comunicação ao enviar as perguntas. Les recuerdo que também contamos com interpretação simultânea ao inglês e ao espanhol. A sessão também está sendo transmitida por Facebook, Twitter e YouTube para que mais pessoas possam assistir. A diretora da OPS hará um informe sobre a situação epidemiológica atual em las Américas e abordará alguns passos que devem ser tomados por os países como parte da resposta à epidemia. Acompanho a doutora Etienne, o doutor Jarbas Barbosa, subdiretor da OPS, o doutor Ciro Ugarte, diretor do Departamento de Emergências em Saúde, e o doutor Silvan Alghieri, gerente de incidente para a COVID-19. Doutora Carissa Etienne, por favor.
Thank you, Paulo Lira, and a very good morning to all of you, and Happy New Year. Welcome to the first meeting, first media briefing for 2021. And PAHO is grateful to you for joining us once again. Since the start of this pandemic, over 39 million people across the Americas have become infected by COVID-19, and over 925,000 of them have succumbed to the virus. In the last week alone, 2.5 million people were infected with COVID-19 in our region, the highest weekly cases since the virus first reached our shores. Virtually every country in the Americas is seeing an acceleration in the virus's spread. In North America, the United States is reporting the highest new COVID-19 infections and deaths in our region. California and states across the American South have seen dramatic increases in COVID hospitalizations, with 13 states reporting record-breaking figures. Today, more than 132,000 are hospitalized from COVID-19 in the United States. These are more hospitalizations than during the pandemic peaks in the spring and the summer. These trends in hospitalizations are also being reported in Canada and Mexico, where the local health systems are struggling to keep up with demanding care. For the South and Central America, data from early January suggests that infections are on the rise in Costa Rica and Belize. However, it's too early to tell the impact of the holiday season on the virus's spread. So we are going to have to remain vigilant over the next few weeks. Across the Caribbean, data from early January reveals that many islands saw rapid rises in infections. The Cayman Islands, Dominica, and the Virgin Islands reported a doubling of cases within the last week alone. And cases are growing even more rapidly in Barbados, St. Vincent and the Grenadines, and Bonaire. And as we move to South America, every country has reported a rise in cases over the last few weeks, even in countries that had seen a decline in cases like Chile and Argentina. As our southern hemisphere experiences its summer months, many countries are struggling to limit gatherings and travel, which will most likely fuel infections for weeks and months to come. Scientists throughout the world and our region have also detected new variants of the COVID-19 virus. PAHO's molecular surveillance network spans some 21 laboratories
very interested in immigration and refugees in the Sahel, the northern part of Africa, in the vaccination systems. And also, I should mention the debt reduction program that was part of the G20 discussions in 2020. Those will also be on the agenda in 2021.
So how quickly do you think that there could be some decisions? You know, you've advocated for an extension of the debt suspension, service suspension initiative, you know, through to the end of the year. You've, and other people have also talked about the importance of expanding the common framework that was agreed between the G20 kind of with the Paris Club. So bringing essentially China into a sort of a common understanding of debt treatments, to expand that to include not just those poorest countries. How soon could there be decisions in that regard? And do you think that both of those moves are likely?
I don't want to prejudge the extension of the moratorium. So to give background, I, with Kristalina Georgieva at the IMF in March last year, said that the poorest countries could not keep paying their debt commitments given COVID. And so then the G20 endorsed that and took that up in starting in April. And I was pleased to see the moratorium implemented through a G20 process called DSSI. That's now in place through June 30th. And so you're right, there's an issue of can it be extended to the end of the year? I think that the importance of this is it saves the poorest countries a lot in debt servicing, and that gives them resources that they can apply to COVID-19 response and to the really the economic catastrophe that many of them are facing. You know, tourism has stopped, remittances have stopped, commodity prices in many areas are lower, and food insecurity is a big challenge. And education, I want to keep coming back to that. Schools are still closed in some parts of the world, and that's taking a stiff toll on children because they tend to move backward if they're not in school. All of those problems need resources, and so the debt moratorium helps with that. And so I'm hopeful that it will be extended through the end of 2021. We just saw yesterday Kenya saying it would ask its creditors could they and they have agreement with some of the creditors that they'll stop making payments, which then saves them money, and that's important in their recovery process. Then separately, and I'll be as brief. You know, these are very complicated topics. They involve a lot of money, but the debt itself, the common framework that the G20 agreed to at the end of 2020 is important because it expresses the view that for some countries in deep debt distress, there'll need to be debt relief. And the parameters of that are still being worked on. We work very closely with the IMF. And so one issue that we're able to
ahead. Leaders will face difficult choices as we work to flatten the transmission curve. And that's why we need leaders to act transparently so that the public understands their decisions and the scientific evidence that is behind those decisions, so we can rally people around a shared plan. We need leaders to act in the interest of public health, not political gain, by working together to make the best use of the tools to prevent this virus. Politicizing vaccines and other control measures is not just unhelpful, but it could fuel the virus and cost lives. And finally, we must balance urgency with good planning. We don't have much time to lose, but we cannot beat the pandemic without strong vaccine delivery plans. And that's why PAHO is working with every country in our region to help secure the vaccine doses that countries need to protect their populations. We're also providing support with vaccine demand planning, logistics and cold chain management, surveillance and information system strengthening, health worker training, and vaccine communication planning, among others. Luckily, our region has a strong legacy of immunization and the mounting of immunization campaigns. Thanks to vaccination and surveillance efforts, the region of the America was the first in the world to eliminate smallpox, polio, rubella, congenital rubella syndrome, and measles. For 42 years, worked together to protect people against vaccine-preventable diseases. Through our revolving fund, member states pool their national resources to procure vaccines and related products at the lowest price. COVID will be a challenge, but one I believe that we can meet by working together. Over.
Thank you so much, Dr. Etienne, for these opening words. The first question we got from the journalists, in fact, we got this same question from so many journalists that I'm not able to mention all the names of all the journalists who asked. I put a composite question here. So the question is, the vaccination process against COVID-19 is quite slow in the United States as well as in other countries. How are the vaccination campaigns in our region? What can countries do differently so that more people are vaccinated in a short time? Dr. Etienne?
Thank you for this question. So let's just reiterate that already a few countries in our region have started vaccination, albeit with limited doses and having to prioritize the more vulnerable population, including healthcare workers. Now, we need to understand that the availability of the vaccine in the early days would be limited, given manufacturing and distribution timelines. And of course, because some high income countries have already bought millions and millions of doses. So I think that the next 2 years are going to be critical, as vaccination of a majority of the population will not happen overnight. And I think we have to manage those expectations. If there are not enough vaccines to stop the transmission, then our initial strategy must be to use those vaccines to save lives by prioritizing those at higher risk. And this is precisely why the COVAX facility was created by WHO and its partners. And the COVAX is working to ensure that countries have equal access to safe and efficacious COVID-19 vaccines, and that it doesn't take them a whole year or more to be able to access vaccines. So COVAX is going to offer vaccines, access to a basket of some 15 vaccines. And we believe that distribution will begin by the end of March, and it will target at least 20% of the population with a focus on vulnerable groups. The situation should also improve once more vaccines are approved by national regulatory authorities. And these include vaccines that have already completed phase 3 and are in clinical trials. Today, we have a pipeline of more than 190 vaccine candidates. We're not sure that all of them are going to be approved, but it is encouraging to see that so many vaccines are in development. So working as quickly as possible, scientists from across the world are collaborating and innovating to bring us tests and treatments, but also vaccines. So we are hopeful. We need to plan very well. We need to use this interim period to make sure that every country is ready. And we need to begin the prioritization process, because we won't have all the vaccines that we need immediately, but from March, we should begin to receive some vaccines. Thank you very much.
Many thanks, Dr. Etienne. The next question is a question from Gisela Salomon from the Associated Press. Can you please go ahead, Gisela?
¿Me escuchan?
Yes.
Okay. Thank you. Sobre COVAX, queríamos saber si nos podían dar una actualización acerca de la cantidad de dinero que se ha recaudado para comprar las vacunas en la región y cuántas vacunas se van a asegurar con este dinero, con estos fondos, y si ya han firmado acuerdos con laboratorios, con cuántos laboratorios, y dónde empezarán a entregarla primero en la región y qué cantidad. Porque así como acaba de expresar la doctora Etienne, de que hay algunos países que ya han comprado a través de los acuerdos bilaterales, si esos acuerdos podrían poner en riesgo las vacunas que estén disponibles también a través de COVAX para los países más pobres.
Muchas gracias, Gisela. Dr. Barbosa, por favor, puede contestar a esta pregunta.
Sí, gracias por las preguntas. Mira, ¿cuál es la situación actual de COVAX? COVAX, primero, de los países de la región, tenemos 10 países que van a recibir la vacuna por intermedio de COVAX sin ningún pago. Esos serían países que, si no existe COVAX, provavelmente tendrían mucha dificultad de acceso a la vacuna. Entonces, 10 para recibir a vacuna. Há outros países que são os países que chamamos de autofinanciamento. Há outros 27 países na região que são de autofinanciamento, que han pago um adelanto ao redor para toda a região de 430 milhões de dólares. Isto corresponde a 15% da primeira fase de COVAX, que tem o objetivo de vacunar a 20% da população de cada dos países. Há algumas variações. Alguns países solicitaram menos para 10%, outros 16%, mas em promédio é 20%. Então, esse é o número. COVAX terminou o processo de receber as ofertas ao dia 23 de dezembro. Começou rapidamente a avaliação de las propuestas. Já temos uma quantidade de 2 mil milhões de doses de vacuna assegurada para o ano 2020. A dificuldade é que a grande maioria dessas vacunas estão programadas para entregar-se no segundo semestre. No primeiro semestre, COVAX vai começar em março a entregar a vacuna, pero todavia com quantidades limitadas, porque isso é o que os produtores estão comprometidos com COVAX. Seguimos em negociação com outros produtores. Por exemplo, é muito provável que em fevereiro vamos atender uma pequena quantidade de vacuna para alguns países, que vai ser como uma espécie de piloto para alguns países, ao redor de 1 milhão de vacunas, de doses de vacunas de Pfizer. Ou seja, sigue lá toda a negociação. E seguro que COVAX também se está propondo como uma plataforma para que os países desarrollados que han firmado já muitos acordos e que têm vacunas, mais vacunas que seria necessário para a sua própria população, possam utilizar a plataforma de COVAX, porque o grande objetivo da plataforma e que vai seguir é que a vacuna vai ser distribuída para os países de maneira equitativa. Ou seja, começando com a quantidade que é necessária para os trabalhadores de saúde, trabalhadores sociais da linha de frente, e depois os outros grupos prioritários hasta alcançar os 20% da população, que é o primeiro objetivo da vacuna, salvar vidas, proteger as pessoas que são mais vulneráveis e que têm lá maior possibilidade de desenvolver formas graves e de morrer por la COVID-19. We cannot hear you, Paulo.
Gracias, Dr. Barbosa. La próxima pergunta, temos uma pergunta de seguimento de Gisela Salomón, também para o Dr. Barbosa. Adelante, Gisela.
Sí, quería saber cómo va el proceso de vacunación en la región. Si pueden dar algunos detalles sobre qué países van a necesitar más asistencia, qué errores y qué contratiempos se han detectado hasta ahora en los que ya están vacunando. Y si pueden decir exactamente cuáles son los que están vacunando y cómo ven el proceso.
Gracias por la pregunta. Mira, hay algunos países de la región que ya empezaron a utilizar la vacuna por intermedio de sus acuerdos bilaterales. Entonces, Canadá, Estados Unidos, México, Costa Rica, Chile y Argentina. Esos son los 6 países que ya empezaron. Las cantidades que están utilizando es una cantidad muy limitada, né? Porque essa é a realidade do mundo. Quando muitas vezes se noticia o país empezou a vacinação, as pessoas muitas vezes creem que se empezou uma vacinação massiva. Não é verdade. O país da região que tem uma maior proporção de vacunação até o momento é os Estados Unidos, que está cerca de 3% de sua população. Isso se estima que 3% corresponde a aproximadamente os trabalhadores do setor saúde. Os outros países estão por debaixo de 1%, ou seja, empezaram a vacunação, o que é muito bueno, pero com uma quantidade muito limitada. A OPS está sempre subrayando a necessidade e brindando a cooperação técnica aos países para todos os aspectos ao redor da vacunação, para ter êxito nesse momento. Não é necessário somente ter a vacuna, pero ter uma estratégia de vacunação, ter os profissionais de saúde capacitados, treinados, ter uma avaliação das cadenas de frio, ter todo o processo de comunicação para a população, para os grupos prioritários, quais são as prioridades, ter estratégias, por exemplo, para vacunar em los hospitais a los profissionais de saúde, como chegar a las casas onde vivem as pessoas maiores, ou seja, é necessário ter um plano. Todos os países da região estão llenando uma ferramenta de autoavaliação e, com base nessa ferramenta, estamos brindando mais cooperação técnica para llenar as brechas e fazer com que, quando tenham a vacuna, puedan implementar rapidamente e com muita eficiência uma estratégia adequada de vacunação.
Paulo, you're muted.
I'm very sorry. The next question comes from Julia from the Veja magazine in Brazil. Julia, are you there?
Yes, sorry. Can you hear me? Hello?
Yes.
Okay. So I'd like to know what is whose opinion about the so-called vaccine passport. Like some countries and working places are studying to request or demand a proof of vaccination for COVID-19 so people can engage in public activities such as traveling abroad or going to concerts and things like that.
Dr. Aldigueri, por favor.
Yes, thank you for your question, Julia. At present, WHO is not recommending proof of vaccination against COVID-19 as a tool for introducing changes to the way people are engaging in non-essential occupational activities, in travels, in religious and in cultural activities. In the context of a global limited vaccine supply and limitation on accessing the vaccine, there are challenges related to the logistics of the distribution of the vaccine, and we are in the middle of the pandemic. PAO and WHO have set clear guidance for countries to prioritize the use of the COVID-19 vaccine that is becoming available to them. The top priority groups, as mentioned in many press conference and interviews at PAO, the top priority groups for vaccination against COVID-19 are the healthcare, at this moment, the healthcare workers and the elderly. Additionally, at present, there is a lack of evidence on whether vaccination would reduce the risk of transmission of the SARS-CoV-2 virus. Therefore, at present, the introduction of requirements for vaccine passport or a vaccine passport is not justificable. It would fuel a false sense of security, and ultimately, it would have the potential to trigger the relaxation and adherence to personal protective measures, social distancing measures, and with possibly dramatic consequences on the dynamic of the transmission of the virus, as well as widening the inequities in health. At this moment, we would like to make a call to the public, but also to the local and national authorities and to the private sector and to the citizen to make an effort in understanding the current science behind vaccination efforts and to operate in a spirit of solidarity. We are at the very early days of the COVID-19 vaccine rollout, deployment to the countries, with long months ahead of us. And as of today, the imperatives are the following: to protect our healthcare workers and those suffering of highest mortality, and I mentioned already the elderly, and to continue with the adoption of the public health and protective measures for individuals and at community level. I hope I have answered your concerns and your questions. Over.
Thank you so much, Dr. Alighieri. The next question comes from Svet Lustig from The Lancet. Svet, can you hear us? Can you take the mic, please?
Hi, can you hear me?
Yes.
Thanks a lot for taking my question and Happy New Year. I have two questions. The first one is about the Russian and Chinese vaccines. Is there a front runner in terms of efficacy and safety given the availability of data?
Would you like to do all the questions, Svet?
Sure, with pleasure. And the second question is, to what extent have the Sputnik and Chinese vaccines brought hope to bring sufficient vaccines at an affordable price to the PAHO region, especially in light of potentially insufficient doses from COVAX? Have some of these countries in the region met the Chinese and Russian vaccines with resistance, more so than other vaccines from the West? Is there an estimate of how many doses have been bought so far for each vaccine for each country in the region of the Americas? Thanks a lot.
Thank you, Steve. Dr. Barbosa, if you can please take this question. If you need us to repeat, we will do that, but hopefully you were able to capture all the questions. Thank you. Go ahead, Dr. Barbosa.
Okay, thank you, Svet, or Svit, for the question. Look, it's very important to clarify that we have some countries that have bilateral agreements. This is their decision. We are not involved in any kind of bilateral agreements for any country. We are providing technical cooperation to establish solid national immunization plans. We are providing technical cooperation on regulatory aspects, but the decision to make a bilateral agreement and to purchase a vaccine, it's only for each country. What we are working is to strengthen the COVAX platform. For the COVAX mechanism, a producer, they need to fulfill some requirements. One of them is to be pre-qualified or to receive emergency use license from WTO. Now, we have only one producer that have received this pre-qualification or emergency use license. That is Pfizer. Probably the Moderna vaccine will be the second one in a couple of days. And the AstraZeneca is also providing all the documentation to be the third. Both producers, Gamaleya Institute, that is the producer of Sputnik, and Sinovac, that is the producer of CoronaVac, started the negotiation with WTO pre-qualification team. They will share documentations, they will share the dossier, the data about the clinical trial phase 1, 2, 3, all the information that is required. We only can say something about these vaccines when we review this data. Before that, we cannot say, from our point of view, we cannot say nothing based on press releases from the producers. We are waiting for them to provide this documentation. It's very important that they are interested to participate in COVAX. Every producer is welcome to COVAX, and they need to offer this data so the pre-qualification team can review them very carefully and approve their use. Until then, we cannot say if the vaccine has a better or worse performance in the other vaccines. But again, all producers are welcome to participate in the COVAX, and all of them will need to fulfill this requirement. We have a conversation with more than 16, now see around 16 producers. And all of them will need to be assessed by exactly the same criteria. We have, as I mentioned before, we have already ensured around 2 billion doses for 2021 for COVAX facility and another 1.3 billion for 2022. But this is not enough because this 2 billion will be enough to cover the first phase, to cover the 20% of the population. That is the first objective, and the aim in the first phase is to save lives. But we need to move it further and try to reach 70% of coverage in the population in order to achieve the control of the transmission. Thank you.
Thank you, Dr. Barbosa. Next, we have a question from Jacqueline Charles from the Miami Herald. Jacqueline, are you there?
Yes, hi, can you hear me?
Yes, thank you.
Yes, hi. I wanted to see what PAHO's reaction was to the CDC's requirement for travelers entering into the United States to be tested. We know in the region the testing is still controlled by a lot of health ministries. So is there any concern about the burden this will place in terms of COVID management and the ability of countries in the region to meet this requirement for individuals seeking to come into the US? Thank you.
Thank you, Jacqueline. Dr. Riccardi, can you please take this question?
Thank you, Paulo. Jacqueline, thank you for your question because this is highly relevant for many countries in the Americas. Actually, PAHO has been providing guidance to member states starting in July 2020. And regarding that, PAHO does not support the use of testing as a tool to mitigate the impact of the spread of COVID-19. This is because of several reasons. One is the performance of the tests in the travelers' population, and also the related false sense of security that it generates, because as you know, the result of the test is accurate as the moment of the sample that has been taken, and it may change until the traveler initiates its journey. And also because of the operational implications, including the burden that the requirement of pre-departure tests result might pose on the countries of origin, but also on the countries of destination, and their potential to undermine response efforts on the countries of origin, but because resources could be diverted from other activities yielding greater public health impact. So the public health interventions are a priority and not necessarily the testing. PAHO considerations informed by a risk-based approach for each member state for resuming non-essential international travel were reiterated in a set of documents published also by WHO in mid-December 2020, so a few weeks ago, stressing that the antigen rapid detection tests are not to be used in the traveler population. That since several countries are basing the resuming of international traffic around laboratory testing, PCR would have some public health impact if performed upon arrival. However, the emergence of SARS-CoV-2 variants might also make the use of these tests even less cost-effective. So reiterating that the most important approach is to limit transmission and implement public health interventions in both the countries of origin and countries of destination. Thank you.
Many thanks, Dr. Ugarte. Next, we have a question from the New York Times from Sofia Villamil. And the question is in Spanish. I'm going to read in Spanish. ¿En qué 6 países está la nueva cepa de UK y qué está haciendo la OPS con esos países para mitigar el esparcimiento? Doctor Alighieri, por favor.
Gracias por la pregunta en español del New York Times. Lo que quisiera primero explicar es que hay una cultura de colaboración muy fuerte entre los laboratorios nacionales de referencia de virus respiratorios en la región de las Américas. Trabajan realmente en una red muy activa y el día de hoy 80.000 aislamientos del virus SARS-CoV-2, 80.000, han sido secuenciados en 31 países y territorios de la región. El segundo punto que es importante es que la evolución es muy rápida en la detección y a la hora de las 10 de la mañana día de hoy son 8 países que han reportado el variante detectado y caracterizado en Gran Bretaña, en la región de las Américas. Lo voy a leer para no equivocarme. Son Brasil, Canadá, Chile, Ecuador, Jamaica, México, Perú y Estados Unidos. Y también 2 países de la región han detectado en sus muestras de laboratorio el variante detectado y caracterizado en África del Sur, que son esos 2 países de la región que son Brasil y Canadá. Realmente lo que queremos alentar en los países de incrementar su nivel de alerta, compartir con laboratorios de referencia regionales, y tenemos varios en el Instituto de Salud Pública de Chile, en la Fundación Fiocruz en Brasil, en el CDC de Estados Unidos y otros, compartir sus muestras para una caracterización cuando el país no tiene la capacidad nacional de hacerlo. En términos de medidas de salud pública, las medidas son las mismas, es la implementación estricta de las medidas de salud pública que están en la batería de acciones y medidas que las agencias nacionales de salud han definidas. Pero lo más importante en términos es evaluar lo que está pasando en la dinámica del brote. Cuando un país tiene la sospecha o ha confirmado la presencia de un variante, a nivel subnacional es muy importante comparar la proporción de muestras que son caracterizadas como una variante que tiene otra dinámica y los datos de epidemiología. Es realmente observar la dinámica del nivel local, del nivel subnacional o del nivel nacional, contrastando con la presencia del variante o de una nueva variante en el país. Espero haber respondido a la pregunta del New York Times. Cambio.
Muchas gracias, doctor Aldiguieri. Hay una otra pregunta del New York Times también en español. ¿Por qué en Colombia no se ha empezado la vacunación ni tenemos fecha delegada de la vacuna? Doctor Barbosa, por favor.
Gracias por la pregunta. Miren, hay dos maneras que los países pueden tener acceso a la vacuna. Países hicieron acuerdos bilaterales, de nuevo, son decisiones de cada país que están relacionadas con su presupuesto, su capacidad de comprar las vacunas, y lo hacen con vacunas por su decisión, aprovadas por su autoridad regulatoria local. El otro camino es por COVAX. COVAX, como hablé, y desde el año pasado que nuestro cronograma sigue lo mismo. Vamos a empezar la entrega de las vacunas al mes de marzo. Vamos a empezar con una cantidad limitada, como todos los países que están con acceso a la vacuna hoy tienen un acceso a cantidades todavía limitadas. Los productores están empezando la producción, van a incrementar la producción, o sea, la vacuna va a ser más disponible para el segundo semestre. Pero de parte de COVAX, la expectativa nuestra es que en marzo se comece a entregar a todos los países que adheriram a esse mecanismo. É importante subrayar também que com o acesso à vacuna, com essa quantidade limitada, a transmissão não vai cambiar. Como chamou a atenção, como ha remarcado a diretora, al princípio, a característica da transmissão não vai cambiar por alguns meses. Para poder cambiar a dinâmica da transmissão, há que alcançar uma cobertura de vacunação ao redor de 70% da população. Então, é muito importante, tanto os países que já começaram com essa quantidade limitada, pero que já começaram, como para os países que vão receber em março por COVAX, a recomendação é exatamente a mesma. Há que manter todas as medidas que sabemos que são efetivas para prevenir a transmissão. Usar as cobre-bocas, as mascarilhas, manter a distância das outras pessoas, evitar as aglomerações, ou seja, todo isso tem que seguir porque durante muitos meses em todo o mundo, essas são as medidas que vão a proteger as pessoas para não ter a COVID-19.
Muchas gracias, Dr. Barbosa. En seguimiento, llamamos a Gisela Salomón para hacer una pregunta. Adelante, Gisela.
¿Me escucha? Esta pregunta tiene que ver con Brasil. El Ministerio de Salud brasileño hizo un acuerdo para la compra y la venta de 40 millones de jeringas y la entrega debería empezar este mes, según ha dicho el periódico Globo. ¿Cuándo debe terminar esa entrega? Globo reportó que hubo una demora de 3 meses para firmar ese acuerdo. ¿Por qué ha sido?
Doctor Barbosa, por favor.
Gracias por la pregunta. La OPS tiene el Fondo Rotatorio de Vacunas, que es un mecanismo que funciona hace más de 40 años en la región este mecanismo hace todas las compras de vacunas para muchos países de la región, incluso también hace compras para Brasil. Por ejemplo, las campañas de vacunación de Brasil contra el sarampión el año 2019 fueron realizadas con vacunas adquiridas por el Fundo Rotatório de Vacunas. Brasil es un participante importante del Fundo Rotatório. También los países pueden adquirir las jeringas por intermedio del Fundo Rotatório de Vacunas. Hasta hoy, 5 países ya han solicitado la adquisición de jeringas por parte del Fundo Rotatório. Como es el proceso, el país hace la solicitud, la OPS entra en contato con los productores que son precalificados para que se tenga calidad de los productos y la OPS entrega al Ministerio de Salud del país cuál es la cantidad, cuáles son las fechas y cuál es el costo. Y el país hace la decisión. Entonces, hay un pedido de Brasil para 40 millones de jeringas que se van a entregar entre março e abril, e a decisão sobre a conclusão da compra e para receber as jeringas la toma o Ministério de Saúde. Nós outros facilitamos esse processo para que os países possam ter mais condições em seus programas de vacinação. Em Brasil também é importante ressaltar que, como é um país federado, muitos estados e municípios fazem as compras também de jeringas para a vacinação. Então, há muitas oportunidades ou distintos caminhos para que o país possa ter acesso às jeringas, que são parte importante. Como falei antes, não basta ter a vacuna, há que ter toda a infraestrutura, há que ter tudo o que está ao redor de la vacinação para que se pueda efetivamente ter acesso a esse grande benefício que é o acesso à vacuna. Gracias.
Muitas gracias, Dr. Barbosa. Em seguimento, outra pergunta específica de um país. Lídia Lopes, de La Prensa de Nicarágua, pergunta: enquanto a vacunação em Nicarágua, se ha concretado quando inicia sua distribuição e aplicação? As autoridades de Nicarágua já lhe apresentaram um plano de vacunação? Se é assim, que destacam de este informe? Dr. Ugarte, por favor.
Bueno, en relación con la vacunación, el doctor Jarbas puede responder más apropiadamente. Sin embargo, hemos estado en contacto muy estrecho con el gobierno de Nicaragua. El apoyo al programa de inmunizaciones desde el punto de vista de la preparación, de la planificación y también de afinar los aspectos operacionales están muy avanzados. Nicaragua tiene un programa de inmunizaciones muy importante. Así es que paso al doctor Jarbas para que pudiera complementar respecto a la vacuna de COVID-19. Adelante.
Gracias, Ciro. Solo para complementar, hay en la prensa algunos informes que Nicaragua está en negociaciones con el Instituto Gamaleya, que es el productor de la vacuna Sputnik. Eso, de nuevo, es una decisión de cada país y seguro que la autoridad regulatoria de Nicaragua va a hacer la evaluación de la seguridad, de la eficacia de la vacuna. Por parte de COVAX, Nicaragua está, como todos los otros países, en ese cronograma para entrega en marzo. Y esa es la diferencia de COVAX, para que todos los países puedan tener acceso cuando la vacuna esté disponible. O sea, no va a haber como una preferencia por uno u otro país. Todos los países van a recibir la cantidad de vacuna que se tenga, se va a distribuir de manera equitativa a los países. Entonces, nuestra expectativa es que en marzo ya vamos a empezar la distribución de las vacunas por el mecanismo COVAX. Gracias.
Muchas gracias, Dr. Barbosa. La próxima pregunta viene de Corey Robinson, del Sunday Gleaner en Jamaica, y viene en inglés. Voy a leer en inglés. After almost a year battling COVID-19, the Jamaican government has only so far approved 8 testing labs to do PCR and antigen tests locally. The government claims it is awaiting PAHO's partnership to do more sites and cannot move any speedier than PAHO allows. What is causing a delay in testing labs being approved by PAHO? Can you explain the approval process? What are the implications if the government does not wait for PAHO? Dr. Alighieri, por favor.
Thank you for this question from Jamaica. First, I'd like to highlight that Pan American Health Organization and the Ministry of Health of Jamaica and the University of West Indies had a very close collaboration since the beginning of the pandemic. By the end of February 2020, there were 2 references lab set up, trained and equipped in Jamaica at the National Public Health Lab and at the University of the West Indies. And step by step, the Ministry of Health has expanded the network of PCR laboratories. The most important aspects that I'd like to highlight is first that in terms of reagents, through donations and through the access to the PAO Strategic Fund, reagents can be procured and deployed to countries, including to Jamaica. So it's also a source of equipment and reagents that countries have the option to activate. The second important aspect is really the game changer that we have been working very closely with the countries starting September, which is the expansion of the laboratory network at the subnational level using antigen detection rapid diagnostic test. And we have deployed to Jamaica through donations this rapid test detecting antigens that allow the local level to characterize almost immediately symptomatic patients. And but there is also an access through the PAO Strategic Fund to the procurement on the international market and the rapid deployment to the countries of this test. So really, the PAO response team, including the virology team, is ready 24/7, even for training virtually and for deployments of personnel to assist directly. This is what was done with Jamaica, and we will be ready in the coming months to keep providing direct technical assistance and deploying kits to the countries, including in Jamaica. Thank you.
Estás en mudo, Paulo.
I'm sorry for that. This is the new year. I'm still catching up. So the next question was also asked for many journalists, and it goes like, why does access to vaccine vary so widely among the countries of the Americas? Dr. Etienne, please.
So let me thank you for this question. And this has caused significant stress among some of our member states. Let's face it, inequity is a reality of the world that we live in. And certainly in our region, you've heard it quoted that inequity continues in our region. And in our region, we see inequity along the lines of people living in poverty, along gender lines, along lines of populations in conditions of vulnerability. And that same inequity persists, even when we are dealing with vaccine access. One of the things that we've seen is many countries making individual deals with pharmaceutical companies for vaccines. Most of those countries globally have been high-income countries, and some of them have bought many times more than they need with different producers and manufacturers. So this a lot depends on their ability, on their budgets and their ability to pay. For PAHO, this is extremely important. We've been at the forefront of addressing health inequalities and inequities in the region. I mean, we must recall that from early January, mid-January, we sent information to all countries last year, informing them about the emergence of COVID-19, which was not COVID-19 then, had not been named. And But also importantly, we ensured that all countries in the region had access to tests. We made tests available and training for all of our countries. So by the end of February, most countries had this. So we worked against the inequity there. We also ensured that all of our countries had supplies of PPEs, emergency supplies of PPEs, and some of the other equipment that they needed. So we worked swiftly across every country. And we did that irrespective of income. But importantly, with vaccines, we know, as I said before, that there are not sufficient doses available now. Manufacturers are still producing. Many countries have bought really large quantities of vaccine doses. So it will take some time for those doses to reach some of our countries. A few of our countries made their bilateral arrangements with manufacturers, and they have received limited doses. I think what's important for us to know is that through COVAX, we have addressed some of that inequity in ensuring that all countries, particularly our low-income countries and middle-income countries, will have access to some vaccines. There is history for H1N1. All member states did not receive vaccines until 10 months to 1 year afterwards. And this is what COVAX is addressing: equitable access, equitable early access to vaccines. So this leads me to a final point. Until we have sufficient doses, until we are able to immunize or vaccinate 70% or more of all of our populations, we must continue with the public health measures. And those public health measures are what is going to guarantee us to be able to reduce the spread of the virus. We need to ensure that we detect cases, that we isolate, quarantine, that we are able to communicate with our population. We need to ensure that we do not congregate. We need to ensure that we socially distance, that we wear masks, that you wash hands frequently. Those are the things that are going now in this era to allow us to be able to prevent the wide transmission of the virus. While at the same time we work with COVAX, we work with our member states to ensure access to vaccines, but importantly as well, to ensure that they are well prepared once they receive the vaccine to distribute the vaccine first to priority groups, healthcare workers, first responders, the elderly, those with underlying conditions, and then as vaccines become more available to the rest of the population. So thank you very much again for being with us.
Many thanks, Dr. Etienne. Graças a ustedes todos e todas por participar de esta conferência de prensa. Chegamos aqui ao final de este evento. Por si acaso não podemos contestar a todas as perguntas, lo haremos em seguimento. Asimismo, todos podem enviar perguntas adicionais a la direção de correio eletrônico mediateam@parro.org. Também podem obter mais informações sobre a resposta da OPS à epidemia da pandemia de COVID-19 em nossa página de web, que é a www.parro.org. Volveremos na próxima semana. Que tenham todos uma excelente semana. Hasta luego.